Alright class, you can see here on the screen are some of the activities and exercises to kind of correlate with the eye problems that I have already discussed in the previous lecture that is already downloaded in your Canvas course. If you'll get out Appendix 42, we'll look at our concept of sensory perception with the exemplar of cataracts. Here we have Mary Martin, a 75-year-old widow with osteoporosis, has an appointment with her ophthalmologist this week. The ophthalmologist notes that Mary's cataracts continue to worsen and recommends that she consider surgery. Mary does not admit the fact that she is afraid to have surgery on her eyes. She tells the doctor that she might have the surgery at some point, but that she is too busy to do it right now. The physician gives Mary a new prescription for her eyeglasses, knowing that this will help her vision at least for a little while. Mary is told to increase the amount of light and to use reading glasses or a magnifying glass for reading. So as you can see from question 1, what nursing diagnosis would be appropriate for this client? And obviously with just this little bit of information that's been given to us about Mary, there's a few answers that would be appropriate for this patient. As I read about her situation, I look at her safety, altered safety as exhibited by impaired vision. That's something that really comes to mind and concerns me somewhat. Also, knowledge deficit, because she probably doesn't have all the information down correctly, which is probably causing her fear of having the surgery, and her excuse is that she's too busy and she doesn't have time right now to have the surgery. But we're kind of going to let her be okay with that, and the physician just kind of adjust her eyeglasses, which will improve her vision just temporarily. But we know with cataracts that they will get progressively worse, and she will eventually have to have the surgery. Question 2, how will the nurse address the client's concerns regarding surgery? And I think that's just what I began to talk about. I think it's necessary that we sit down with Mary and explain exactly what the procedure entails, what kind of anesthesia is needed, is there going to be pain with it, and then what is going to be involved with the post-surgery care. I think once we do that, we may give her a little bit more information that makes her somewhat more comfortable in having the procedure. And it would be nice to bring either a friend or a family member, even a neighbor, along to kind of give her some support, because she is a widow, she's alone, she lives alone, and it would be just nice to have somebody there to kind of listen to exactly what would happen or what is going to happen when she has the cataract surgery. And I think it's necessary to explain to her about what cataracts do, that they do get progressively worse, that there's only so much we can do as a temporary fix, and this is what obviously her physician is providing for her now, just helping get her glasses to make her see a little bit better. Right now we're giving her a magnifying glass so that she's able to read a little bit better. But this will only be a temporary fix, and she will eventually need to have the surgery, and I think that's important to let her know that cataracts will get progressively worse. And what factors may impact Mary's home care? We don't know much about her situation and her home environment, but stairs are always a concern, and making sure if she does have stairs that they have handrails and proper lighting, and there may be some skid resistant materials on the stairs so she wouldn't slip and fall. And also looking at the way her furniture is laid out, that there's not a lot of clutter, which would cause her to trip and fall, along with rugs and things like that, and that she does have an environment that has good lighting. And it's always a concern when somebody who's 75 years old does live alone. There's no one there to assist her with anything. She's pretty much on her own. She does have this other problem with osteoporosis, which if she falls, her bones are a little bit more fragile, making her at a higher risk for a fall, either to her hip or her leg or even her upper extremities. So those are some of my concerns when we talk about this particular person and her situation with her cataracts. All right, so you guys can kind of look through that and maybe come up with some other answers. That's kind of what I kind of formulated as I looked at Mary Martin's situation. Okay, if we move on to Appendix 43, and this just looks mostly at the safety issue. We have a patient here now that went for surgery for cataracts. The client is 78 years old and lives alone on a third floor walk-up with no elevator. First of all, I'm very concerned that someone 78 years old is living on the third floor that does not have an elevator. Oh my heavens. I mean, she's walking or he's walking up 3 flights of stairs. How does this person get their groceries up to their house? And we don't know what other comorbidities this patient may have, whether or not there's any respiratory or cardiac issues involved. So what safety issues will the nurse address when teaching this patient? First of all, I'd like to know the situation with the stairs. And if there's a button where she could, call if there was a situation where she did fall with, as she was going up the stairs. Very, very concerning to me. Also, I'd recommend, too, that she has appropriate and well-fitting shoes on to prevent any chance of, slipping or falling or catching her shoe on anything, and that the stairs are free of any type of clutter whatsoever, and definitely that they have a handrail on them. What issues place this patient at increased risk for injuries? Definitely her age and knowing a little bit about her health history. Plus, she just had cataract surgery. We don't know how her vision is right now. Usually it's pretty good post-procedure. We want to make sure that, she's still able to carry on with activities of daily living, that if there's any eye drops that have to be instilled, she knows how to do that, and that, she's aware of any changes in her sight when it's necessary to call the doctor for a possible complication of the surgery. Question 3 is how might the development of cataracts interfere with the older adult's ability to meet developmental milestones? We don't know too much about her cognitive ability as well, and her other comorbidities that she may have at 78 years of age. We know she obviously now has alteration in sight with cataracts, and is there any other sensory alterations besides the sight that could definitely interfere with her developmental milestones? But we do know from all that we've talked about, from even Nursing 100, that as one begins to age, there are normal aging processes that occur within all the systems. So those are things that we want to kind of think about. And then question 4, prior to cataract repair, what interventions might the nurse initiate to help the older adult meet his or her developmental needs? First of all, just explaining to her about cataracts, how they came to be, and what was exactly done in regards to the surgery, and then what is her role in meeting those outcomes of a good healing with her eyes, and that to definitely assess whether or not her eyesight is much better than it was. If there was any medication such as eye drops or any drugs that she needs to be on, that she's aware of how those work, and is she able and cognitively, and does she have the motor skills to be able to install those medications into her eyes, and talking about some of the other risk factors which could cause her to develop cataracts. Again, no alcohol. Does she smoke? And really encouraging her to wear sunglasses when she's out in the sunlight. And if she drives too, can she self-assess herself to know that she's seeing okay and that she's not putting herself or anybody else in any type of jeopardy when she's out driving a car. And possibly she'd be a good candidate to take supplemental vitamins that your book talks about for patients that might have eye issues as well, and to definitely see her physician whenever suggested on a yearly or maybe even twice a year to assess her eye health as well. So that's Appendix 43. So let's move on to Appendix 44. We're going to kind of change gears now and talk about the patient that has glaucoma. We have Jane Baker, is a 75-year-old female who recently widowed. She and her husband were married 40 years when he died from cancer. She has limited income because her husband's pension terminated when he died. She receives $652 a month in Social Security benefits. Mrs. Baker does not see particularly well. She's in excellent health. The only health-related problems, as she's aware, are osteoporosis and glaucoma, for which she sees an ophthalmologist on a regular basis. The only prescription drugs and over-the-counter supplements she uses are Fosamax calcium and latanoprost ophthalmic solution, which is Zalatan eye drops to manage her glaucoma. Her dose is 1 drop in each eye once a day. Her only complaint about the eye drops is the cost. Although Mrs. Baker has a car and a driver's license, she does not drive very often due to problems with vision. She prefers that friends and family members take her places. She needs to go. At her latest visit to the ophthalmologist, the doctor notes increased intraocular pressure. Based on the information provided, what might be the cause of Mrs. Baker's increased intraocular pressure? There could be a lot of things. Her glaucoma could be progressing. Maybe she ran out of the eye drops and she's not taking them because of the cost. I do want to tell you that I did research this medication. It is very expensive. It's about $200 a month. So as you can see, with her only getting $652 a month, it doesn't leave her much to pay her other bills or other her other basic needs as far as food and her utilities, and maybe she has to pay for insurance. Who knows? So it is very expensive. So those could be possibly the reasons why her intraocular pressure has definitely increased. What is the priority nursing diagnosis? You guys can kind of come up with those. Definitely, she's got financial issues. Her sight is poor. So those are things that, she's kind of lost somewhat of her independence as well, because now she has to depend on family and friends to drive her around, even though she has a driver's license and a car. What resources might be available to help Mrs. Baker meet her needs? We need to advocate for these patients. These drugs are extremely expensive. Might be necessary to let her physician know, and many times they can call the drug reps who bring these into the offices for the physician to use as their routine med for a patient that might have something like glaucoma. There's a lot of help for these patients out there. Sometimes these patients can get these meds for a few months absolutely free, but we have to advocate for them and get them some kind of financial assistance. Too much for this. This woman doesn't have much money to live on as it is, let alone to pay for this. But we know if she does not get this intraocular pressure under control, she could eventually go blind. So something to think about. All right. Let me bring that back up again. Okay. Let us look at the next activity. Again, looking at the concept of safety in regards to glaucoma. It says what interventions are appropriate for the nurse to initiate to ensure safety for the patient with glaucoma, we want to make sure that intraocular pressure is in check. So we want to make sure that, if she exercises, what kind of exercises she's doing, that if she's on medication, that she's compliant with that medication, and that we want to make sure that too, what kind of changes in her vision has she seen over the last few months, okay? Because maybe the pressure's going up and it definitely is affecting her eyesight, okay? Why would it be important for the nurse to give anticipatory guidance to the patient with glaucoma? Because we know that if this is not kept under control, and if we don't do something to relieve that pressure, we do know that this patient could eventually go blind, okay? So the next patient situation is Susan Parkerson is a 40-year-old woman with severe persistent asthma. In addition to receiving bi-monthly immunotherapy, she takes an inhaled corticosteroid with a long-acting beta agonist and an antihistamine daily. Each year she has 4 or 5 acute exacerbations of asthma that usually require a taper of oral prednisone. So what are her risks? And her big risk is obviously being on a steroid. And it looks to me that, she's only 40 years old. She looks like she has a really very unstable situation with her asthma, not really under good control. I mean, 4 or 5 exacerbations is not good. And there's something unfortunately wrong with this situation where either the patient has not been educated well on her asthma, or her meds are not within good control. Maybe it's time to go back to the drawing board and reevaluate her asthma. She might need pulmonary function testing because we really would like to avoid her going on any type of steroids, which is obviously needed for the inflammation. But unfortunately, it is a big risk factor of why she might acquire glaucoma. And what client teaching should the nurse provide Ms. Parkerson to reduce her risk of developing glaucoma? I kind of said that. Maybe she might benefit well from high-dose antioxidants and zinc for her eye health. And again, to get her glaucoma, not her glaucoma, but her asthma under control. And that might be something her family physician might want to definitely do, or maybe suggest she see a specialist with respiratory issues and respiratory diseases. Okay? Okay, and then let's move on to Appendix 46, where now we're going to look at macular degeneration. We have Margaret Marlborough, 58 years old. She's a librarian. She's in good health. She has never smoked and has no history of heart disease. She has made an appointment with her ophthalmologist because she has noticed pages getting blurry, and she sometimes can't see her co-worker's face clearly. At first she thought her glasses might be dirty, but cleaning them didn't seem to help. So as you can see, based on this information, what visual examinations will be performed? She probably is going to do some of those ones we talked about that were on the PowerPoint, maybe a Snelling and a Rosenbaum test, and then some of those other more intricate tests, like a fundoscopy, tonometry, all those other ones that were discussed in the PowerPoint, okay? We want to find out exactly what's going on, and it looks like she probably has the beginnings of macular degeneration, and it's quite interesting because she is only 58 years old and really doesn't have any other significant risk factors. She's never smoked and she really has no history of heart disease. So what type of AMD is Margaret likely to have? I think she has the dry macular degeneration, but remember that can progress obviously to the wet or to the exudate type of macular degeneration. And again, what is the priority nursing diagnosis? Her biggest problem is obviously her vision has definitely changed, very blurry, and it must be significantly has declined because she can't even see her coworkers' faces clearly, and that to me is a real big concern. What interventions will be of most benefit to Margaret? I think first of all, diagnosing exactly what is going on and how advanced her macular degeneration is. Again, some of the high doses of antioxidants and zinc would be very helpful for her. And definitely, assessing to see if she's safe to, drive a car. But remember, she's a librarian, so it's very important that her eyesight is pretty well intact, because she has to see to be able to look at books and offer books to people that come in or whatever. So her condition is definitely very concerning. And if you go back and look at your book, this type of macular degeneration is very slow to progress. And I would also suggest that she have better lighting, and make sure that, in order to see better, that, she would have good lighting. And that's some of the interventions that would be beneficial to her. Remember, she really is exhibiting very typical manifestations of early age-related macular degeneration. All right, then lastly, let's move on to the next appendix, and this would be, again, linking macular degeneration with the concept of health, wellness, and illnesses. It says, what challenges might the client with late-stage age-related macular degeneration experience related to physical activity? Think about that. Obviously, sight will definitely be affected, so anytime you're more active and more physical, you run the risk of more chances to get injured, okay? What effect might AMD have on the client's ability to maintain good dental hygiene? And this question is quite interesting. I think the correlation really has to do with periodontal disease. I kind of read a little bit more about this, and it talks about the relation between periodontal disease and cardiovascular disease, but they're also saying new studies are showing an increased levels of C-reactive protein, which is an acute phase reactant protein, used as a biomarker for inflammation, and those are associated with a higher risk for developing age-related macular degeneration. So that's where the kind of correlation comes into be, okay? And then if we look at macular degeneration with the concept of cognition, what effect might advancing macular degeneration have on a client's cognition? And part of what we learn and see and process are all through our senses. And if our eyesight is definitely altered, that's definitely going to affect our cognition. Plus, it just doesn't keep us as alert, aware, able to process as well, and it makes our cognition really begin to decline, or not really stay on that even keel. And we see people that definitely have alterations in their sensory perceptions due to macular degeneration, definitely become even more withdrawn, more socially isolated, definitely affecting their cognitive ability. And so what strategies can the nurse implement to promote cognitive functioning? I would just be sure that patients with macular degeneration are being seen by their doctor, and we are trying to, depending on whether or not they have the dry or wet, which most people have the dry, that we can continue to slow down the progression of the disease process, which definitely will affect the vision of the person. So that's kind of how you have to look at these questions. But there are more than one answer. These questions are meant to just make you think. And obviously you have to have some awareness of the pathology behind these eye disorders and who's at risk, how do they manifest, what is the outcome if no treatment is given, how are they diagnosed, and what are the treatments. And those are the kind of things you want to think about when you're looking at some of these eye disorders, okay? And you can see how many times when we do have alterations in any of the senses, how it does affect other concepts that we have actually talked about. And again, we're looking at cognition, all right? So hopefully that helps a little bit, but you might want to go over that and make sure you understand the differences between these three types of eye disorders, what structures are involved, what is the outcome when they're left untreated, is the person going to be permanently blind, and you know, is there any successful treatment for these to definitely avoid the person in having total blindness or serious declining eyesight. All right, we're going to look at our concept of mobility, and our exemplar is normal versus abnormal mobility. And what I have here is Appendix 48. And what I want you to do on your own is to look at these different body systems and think about what kind of changes you would see within that system when someone becomes immobile. And I'll give you an example of the first system here. If you look at the integumentary system, what you would definitely see when someone becomes immobile is increased pressure on the skin, which would be aggravated by metabolic changes. And of course, we know with decreased circulation to the tissues, it causes ischemia to the area, which again leads to pressure ulcers. So that's kind of what I want you to do with this particular activity or exercise. Respiratory, we've talked about this numerously. What exactly happens to that person that's lying in bed, not moving around? What kind of changes are we going to see within the respiratory system, cardiovascular system? What happens with metabolism, elimination, musculoskeletal, neurological, psychological, and then look at what happens when children become immobile in regards to the development of a child, the adolescents, adult, and the older adult. So work on that independently, and you know, if you have any questions, let me know, okay? Okay, continuing with our concept of mobility, our second exemplar here is osteoarthritis. So let's just go through this PowerPoint, okay? It is the most common form of arthritis, and depending on the severity of acquiring osteoarthritis, most people will get this as they age. It's part of the normal aging process because it develops as a wear and tear on joints, cartilage, on breakdown cartilage, where you have bone on bone. And some of the affected areas are the hands, the knees, and the hips. It's a degenerative joint disease, localized, generalized, idiopathic, progressive erosion of joint articular cartilage, which can also develop what we call bone spurs. And the etiology is it can be primary or idiopathic, which we don't really know why it happens. There's no single clear cause. secondary arthritis, some underlying condition, maybe due to trauma, bone disease, or even inflammatory joint disease. Now, the risk factors are that excessive weight contributes to osteoarthritis. That's why it's important as we age to maintain an ideal body weight, participate in moderate exercise program, and inactivity and excessive exercise can lead to premature degeneration of cartilage. The onset of OA is usually gradual or insidious, and what else, along with pain, is the stiffness in one or more joints, and pain may be referred to other parts of the body. Complications are presentation of OA in the older adult leads to a lot of pain and degeneration of those particular areas with the joints, and of course with that pain and stiffness can lead to unsteadiness, and so the person now has an increased risk of falling. And collaboration, no treatment is available to stop the progression, but early treatment is beneficial, and learn to live with a chronic disease. Some of the non-pharmacological therapies are education, just knowing what OA is about, weight reduction, exercise, but in moderation, and general specified rest, okay? Early treatment too, as far as when it becomes progressively worse, to help with some of the unsteadiness while ambulating, is to have the ability to use a cane, crutches, or walkers, help with that functional ability. Sometimes heat to painful joints, kind of alternated with cold applications to help reduce a lot of the inflammation, the pain, and the swelling. And even PT is also very helpful as well. So that's a little bit about OA, all right? And then lastly, I have a few questions on osteoarthritis. Okay, question 1, an obese client with degenerative joint disease is being managed pharmacologically with aspirin therapy. The nurse determines that additional teaching is needed when the client makes which of the following statements? And here's your choices, so think about it. And the answer is, I take my aspirin when I have extreme pain or stiffness. The rationale behind this is it's important that people continue to take that on a daily basis. Aspirin therapy is continuous and is effective only if therapeutic blood levels are reached. It is not to be taken intermittently. And the other statements are appropriate self-care measures when taking aspirin for osteoarthritis. Question 2. The nurse collects data from a patient with suspected OA. The nurse elicits information that will confirm which of the following manifestations of osteoarthritis. Elevated SED rate, dull aching pain in the joints, elevated white blood cell count, or positive rheumatoid factor. I'll give you a couple minutes to think about that one. And the answer is dull aching pain in the joints. And dull aching pain after rest or intensified pain after activity with stiffness is characteristic of osteoarthritis. And an elevated SED rate and positive rheumatoid factor are characteristics of rheumatoid arthritis, not osteoarthritis. And there are no lab tests that diagnose osteoarthritis, and an elevated white blood count is not characteristic of this disease. Think back to our immunity. That's what we look at for any type of infection. Which of the white blood cells are elevated to kind of give us a clue as to what is causing the infection. Okay, a 63-year-old client has recently been diagnosed with osteoarthritis, and the nurse is teaching the client about activities to manage the disease. The nurse includes which of the following in teaching? Ice painful joints for 60 minutes, perform vigorous exercise, take cod liver oil as a supplement, or do not overuse affected joints. Give you a minute to look at those. And the answer is do not overuse affected joints. As you look at the rationale, ice and heat are used is a good choice for some of the inflammation and achiness. But we want to keep it on there for an hour. Usually the most is 15-20 minutes, and mild exercise balanced with rest is best for the affected area. So I think that's it. So we pretty much concluded what we would have gone over in class, but continue to read your assigned reading for week 6, day 2. And if you have any questions, bring it up in class next week when we meet on Tuesday. So have a great weekend, everybody, and I hope this helps. Just to kind of give you an idea of what we would have done in class if we had been there on Thursday. So hope you're having a good holiday weekend, and I'll see you all on Tuesday. Enjoy your Saturday and Sunday.